My name is Nicole Arellano, and this is my video presentation on acidosis and alkalosis. Normally, the systemic arterial pH of the body is between 7.35 and 7.45. This is maintained by extracellular and intracellular chemical buffering with respiratory and renal regulatory mechanisms. The central nervous system and respiratory system are responsible for the control of arterial carbon dioxide tension, or PaCO2. The renal system is responsible for the control of plasma bicarbonate by excretion or retention of acid or alkali. There are four general types of acid-base disorders, namely metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Simple acid-base disorders is when there is a primary acid-base disturbance with a compensatory response. So, for example, if the primary disturbance is metabolic, there would be respiratory compensatory response. This table shows the prediction of compensatory responses to simple acid-base disorders, and the pattern of changes is seen in the values of pH, bicarbonate, and carbon dioxide. Mixed acid-base disorders is when there are independently coexisting disorders and not just compensatory mechanisms. This is usually seen in patients in the critical care units. To diagnose this, an iron gap should be determined, and there should be presence or correction to a normal serum albumin of 4.5 grams per dl. This table shows mixed acid-base disorders with their corresponding expected blood gas and electrolyte values. So there are steps in approaching acid-base disorders. First, the blood samples for electrolytes and arterial blood gas analysis must be drawn simultaneously prior to therapy. Second, bicarbonate is calculated and compared to the value in the electrolyte panel. The calculated value should agree within 2 millimoles per liter. If not, it's either the samples are not drawn simultaneously or there is a laboratory error. Third, the anion gap is calculated. The formula is anion gap equals sodium minus chloride plus bicarbonate. The normal value ranges from 6 to 12 millimoles per liter. Fourth is to know the 4 causes of high anion gap acidosis. Fifth is to know the 2 causes of non-anion gap acidosis. Sixth is to estimate the compensatory response as showed in the previous slide. Seventh is to compare the change in anion gap and the change in bicarbonate. And lastly is to compare the change in chloride with the change in sodium. So now I will discuss on the general types of acid-base disturbances, starting with metabolic acidosis. Metabolic acidosis may be due to an increase in endogenous acid production, loss of bicarbonate, or accumulation of endogenous acids due to inappropriately low excretion of net acid by the kidneys. It has various effects on the body, such as increased ventilation due to decrease in pH, depressed intrinsic cardiac contractility but normal inotropic function due to catecholamine release, peripheral arterial vasodilation and central vena constriction, decrease in central and pulmonary vascular compliance, and depressed CNS function manifested with headache, lethargy, stupor, and even coma. The goal of treatment is to increase bicarbonate to 10 to 12 millimoles per liter and the pH to 7.2. Sodium bicarbonate, IV 50 mg diluted in 300 milliliters of sterile water administered over 30 to 45 minutes during the first 1 to 2 hours of initial therapy may be given for cases with severe acidemia or pH of less than 7.1. There should also be careful monitoring of plasma electrolytes. So there are 2 main categories of metabolic acidosis: the high anion gap metabolic acidosis and non-anion gap metabolic acidosis. So under high anion gap, lactic acidosis, ketoacidosis, toxin-induced acidosis, and chronic kidney disease. Under non-anion gap, GI bicarbonate loss and renal tubular acidosis. So lactic acidosis may be secondary to type A or poor tissue perfusion seen in shock or cardiac failure, severe anemia, mitochondrial enzyme defects, or inhibitors such as carbon monoxide and cyanide. or type B, or aerobic disorders, seen in malignancies, nucleoside analog reverse transcriptase inhibitors in HIV, diabetes, renal or hepatic failure, thiamine deficiency, severe infections, seizures, or drugs or toxins. The treatment for lactic acidosis is to correct the underlying condition, restore the tissue perfusion if inadequate, and to give alkali therapy for acute severe acidemia of pH less than 7 to improve cardiovascular function. The next is ketoacidosis. In diabetic ketoacidosis, there is increased fatty acid metabolism and accumulation of keto acids. This occurs in insulin-dependent diabetes mellitus patients in association with cessation of insulin or an intercurrent illness, which increases insulin requirements. This is most often accompanied by hyperglycemia. So the treatment for diabetic ketoacidosis is fluid resuscitation with isotonic saline, since typically patients are volume depleted, but the mainstay therapy is IV regular insulin. The next is alcoholic ketoacidosis. This is associated with binge drinking, vomiting, abdominal pain, starvation, and volume depletion. So this is due to elevated ketones. The treatment for this is IV administration of saline in glucose, or 5% dextrose in 0.9% sodium chloride, and to correct coexisting electrolyte abnormalities such as hypophosphatemia, hypokalemia, and hypomagnesemia. Next is toxin-induced acidosis. In salicylate ingestion, there is increased lactate production. The treatment for this is vigorous gastric lavage with isotonic saline, at least 1 round of activated charcoal per nasogastric tube, 1 gram per kilogram up to 50 grams, IV sodium bicarbonate to alkalinize urine and maintain urine output, and to correct hypokalemia if present. Next is alcohols. So acidosis occurs when measured osmolality exceeds the calculated osmolality by more than 10 to 15 millimoles per kilogram of water. The 3 alcohols that may cause fatal intoxications are ethylene glycol, methanol, and isopropyl alcohol. In ethylene glycol ingestion, there is increased lactate production secondary to inhibition of tricarboxylic acid cycle and altered intracellular redox state. The presence of oxalate crystals in the urine will help in the diagnosis. The treatment for this are saline or osmotic diuresis, thiamine and pyridoxine supplements, fomepizole, and hemodialysis is considered when the arterial pH is less than 7.3 or the osmolar gap exceeds 20 milliosmoles per kilogram. So in methanol ingestion, there is lactic acid, keto acids, and other unidentified organic acids in the blood. The treatment for this are general supportive measures, fomepizole, and hemodialysis. The last alcohol is isopropyl alcohol. Plasma levels of more than 400 milligrams per dl is already life-threatening. This is metabolized by alcohol dehydrogenase to acetone. And the treatment for this are supportive therapy, IV fluids, pressors, ventilatory support if needed, and hemodialysis is considered if there is prolonged coma, hemodynamic instability, or if the plasma level is more than 400 milligrams per dl. The last major cause of high anion gap metabolic acidosis is chronic kidney disease. So metabolic acidosis is usually seen in stages 4 and 5. The pathophysiology behind this is poor filtration and reabsorption of organic anions. So in chronic kidney disease, the number of functioning nephrons become insufficient to keep pace with net acid production. So the treatment for this are oral alkali replacement to maintain bicarbonate to approximately normal values. Sodium bicarbonate tablets may be given, or sodium citrate or Scholl's solution. So we go next to non-anion gap metabolic acidosis. So in GI bicarbonate loss, such as in diarrhea, there is higher concentration of bicarbonate in stool compared to plasma. In renal tubular acidosis, we have 3 types. the proximal renal tubular acidosis or type 2, the classic distal or type 1, and the generalized distal or type 4. In proximal renal tubular acidosis or type 2, this is due to generalized proximal tubular dysfunction. Glycosuria is usually present, as well as generalized aminoaciduria and phosphaturia. In classic distal renal tubular acidosis or type 1, there is hypokalemia, low urinary ammonia excretion, high urine pH, and commonly there is hypocytrituria and hypercalciuria. In generalized distal renal tubular acidosis or type 4, there is dysfunction of the potassium and acid secretion. So there is depressed urinary ammonium excretion and hyperkalemia. So the treatment for non-anion gap metabolic acidosis, for the non-renal causes, sodium bicarbonate via IV or orally can be given. For renal causes, in type 2, a combination of sodium and potassium citrate may be given. In type 1, so administer potassium if there is hypokalemia and sodium citrate or Scholl solution or sodium bicarbonate tablets are given. In type 4, the goal is to correct acidosis and hyperkalemia. The next general type is metabolic alkalosis. So in metabolic alkalosis, there is elevated arterial pH, increase in serum bicarbonate, increase in carbon dioxide if there is already compensatory alveolar hypoventilation. So this is usually accompanied by hypochloremia and hypokalemia. This may be a result of net gain of bicarbonate or loss of non-volatile acid from the extracellular fluid. So there are two stages for metabolic alkalosis. First, the generation stage, wherein the loss of acid happens, and then the second is maintenance stage, which occurs because secondary factors prevent the kidneys from compensating by excreting bicarbonate. Metabolic alkalosis can be associated with ECFV contraction, potassium depletion, secondary hyperaldosteronism, or it can be associated with ECFV expansion, hypertension, and hyperaldosteronism. So for GI origin, there is hydrogen loss from vomiting or gastric aspiration causing simultaneous addition of bicarbonate, and this is corrected with sodium chloride and repair of potassium deficit with potassium chloride. Next is renal origin, and this may be due to diuretics, non-reabsorbable anions and magnesium deficiency, potassium depletion, post-treatment of acidosis, and post-hypercapnia. So for diuretics such as thiazides and loop diuretics, there is increased distal salt delivery which causes potassium and hydrogen secretion. This is corrected by discontinuing the diuretic and providing isotonic saline. Next is non-reabsorbable anions, wherein there is increased transepithelial potential difference in the collecting tubule, causing potassium and hydrogen secretion, while in magnesium deficiency there is enhanced distal acidification. In potassium depletion, there is increased urinary acid excretion, and this is treated by correcting the potassium deficit. Next is post-treatment of acidosis. So there is metabolism of lactate or ketones which yield an equivalent amount of bicarbonate. And last is post-hypercapnia, wherein prolonged carbon dioxide retention enhances renal bicarbonate absorption and generation of new bicarbonate, and this will lead to increased net acid excretion. So the next is increased aldosterone levels, wherein there is increased net acid excretion, salt retention due to upregulation of epithelial NA channels in collecting tubule to aldosterone, which leads to hypertension, kaliuresis, also due to distal sodium absorption causing enhanced potassium excretion. Also in Liddle syndrome, which is an inherited gain-of-function mutation of genes that regulate the collecting duct sodium channels and can cause hypokalemic alkalosis and normal aldosterone levels. Symptoms for metabolic alkalosis include CNS and PNS changes such as mental confusion, obtundation, predisposition to seizures, paresthesia, muscular cramping, tetany, and hypoxemia. Also, there is electrolyte imbalance such as hypokalemia and hypophosphatemia. So for the treatment of metabolic alkalosis, the first is to correct the underlying stimulus for bicarbonate generation, and the second is to remove the factors that sustain the inappropriate increase in bicarbonate reabsorption, such as seen in ECFB contraction or potassium deficiency. So next we go on to the third type, which is respiratory acidosis. So there is increase in PaCO2, which decreases the pH. So clinical features vary according to the severity and duration of the respiratory acidosis, the underlying disease, and if there is an accompanying hypoxemia. Usually it presents with anxiety, dyspnea, confusion, psychosis, hallucination, and may even progress to coma due to rapid increase in PaCO2, sleep disturbances, loss of memory, personality changes, motor disturbances such as tremors, myoclonic jerks, and asterixis, as well as coordination impairment seen in chronic hypercapnia, and headaches, papilledema, papilledema, abnormal reflexes due to vasoconstriction secondary to loss of the vasodilator effects of carbon dioxide. So it can be caused by severe pulmonary disease, respiratory muscle fatigue, abnormalities in ventilatory control, and respiratory center depression due to drugs, injury, or disease. So for acute respiratory acidosis, there is a compensatory elevation of bicarbonate due to cellular buffering mechanism. So in every 10 mmHg increase in PaCO2, there must be 1 millimole per liter increase in bicarbonate. In chronic, there is already renal adaptation, wherein in every 10 mmHg increase in PaCO2, there must be 4 millimoles per liter increase in bicarbonate. The treatment for respiratory acidosis depends on the severity and rate of onset. For acute, the underlying cause must be reversed with restoration of adequate alveolar ventilation, either via tracheal intubation, assisted mechanical ventilation, or oxygen administration. For chronic cases which are difficult to correct, the goal is to improve lung function as the primary focus. So for the last general type, respiratory alkalosis, there is alveolar hyperventilation, which leads to decreased PaCO2 and increased bicarbonate and PaCO2 ratio, which leads to increased pH. So clinical features vary according to duration and severity of the disturbance. So there can be reduced cerebral blood flow due to the rapid decline in PaCO2, which will manifest as dizziness, mental confusion, or seizures. Cardiovascular effects due to acute hypocapnia, such as decrease in cardiac output and blood pressure, as well as cardiac arrhythmia due to changes in oxygen unloading by the blood. And electrolyte imbalance in acute cases due to increased proton-bound fraction and intracellular shifts of sodium, potassium, and phosphate. So causes are hyperventilation syndrome, CNS disease or injury, salicylates, methylxanthines, theophylline, and aminophylline, progesterone, liver failure, and gram-negative septicemia. So for acute respiratory alkalosis, in every 10 mmHg decrease in PaCO2, there must be a 2 millimoles per liter decrease in bicarbonate. While in chronic, which is more than 3 to 5 days, in every 10 mmHg decrease in PaCO2, there must be 4 to 5 millimoles per liter decrease in bicarbonate. So the treatment for metabolic alkalosis is directed toward alleviation of the underlying disorder, and if the patient is mechanically ventilated, Dead space, tidal volume, and frequency may be changed. In patients with hyperventilation syndrome, reassurance, rebreathing from a paper bag, and attention to underlying psychological stress, and beta-adrenergic blockers may be given to ameliorate peripheral manifestations of hyperadrenergic state. That wraps up my video presentation on acidosis and alkalosis. This is my reference. Thank you.